Hello everyone, welcome back. This week we are focusing on 3 more chapters of your clinical imaging book, chapters 13 through 15. Those chapters covered bone tumors, endocrine, metabolic, and nutritional diseases, and there was a chapter that was dedicated to miscellaneous bone diseases as well. So just like before, as we've been continuing each week, the goal is not for you to try and memorize every condition, but we do want to get an idea of what some of these conditions or diseases entail and how they might present on some of our images. So we're going to start off with chapter 13, and just like the first 2 weeks, we had somewhat of an analogy that was used for those chapters. So in this chapter related to bone tumors and related diseases, the analogy or subtitle that you see right here is a polite guess or a break-in. And that's exactly what some of these diseases do. So that's going to be the focus for chapter 13. So as we stated before, we're going to use the analogy of the tumor being a guess or the tumor breaking in. So here's the way we're going to think about tumors going forward. A benign tumor is going to behave like a polite guest in your house. You invited them in. Well, not really in the case of a tumor, but they typically are going to grow slowly. They're going to respect the walls and everything within the residence. And on images, they typically are going to show up with well-defined margins. Sometimes there may be a sclerotic rim, but typically there's not going to be any soft tissue mass. For these type of tumors, they're usually going to carry the suffix oma. With the malignant tumor, it's just the opposite. They're typically going to break in. They're going to move really fast and aggressively. They're not going to respect any boundaries. And on images, they tend to be poorly defined margins. They also have an aggressive periosteal reaction, cortical destruction, and you also might see soft tissue masses with this type of tumor. These tumors usually will carry the suffix sarcoma. So one thing to note about these tumors, most of primary bone malignancy is actually pretty rare. Osteosarcoma is the most common, but it's still not, there's still not a lot of cases in the US. All right, benign bone lesions and bone mets from other organs are more common than seeing these primary bone cancers. So as we've done every week so far, we're going to first try and sort things out and give ourselves some buckets to place these tumors into. So the first sorting, we're going to begin with, is it benign or is it malignant? Benign tumors, we already stated they're going to carry the suffix oma, so that's going to be our oma group. They are common. Usually with these type of tumors, it's going to be an incidental finding. They're going to have very sharp margins, and there's also a narrow zone of transition. So think of osteochondroma, osteoid osteoma, enchondroma, fibrous dysplasia, and a giant cell tumor. Those all fit into this group. With malignant tumors, that's the group that carries the suffix sarcoma. We already stated that they were rare, but they are a very serious group or serious finding. They have a wide zone of transition, a very aggressive periosteal reaction, soft tissue extension, and also this group includes things such as osteosarcoma, chondrosarcoma, Ewing sarcoma, multiple myeloma, and also bone metastasis. So now that we know that we're dealing with tumors, now the next step is to figure out, are they behaving like a guest or are they behaving as if they broke into your residence? So the first thing we're going to look at are these 5 clues, and the clues that are typically going to be looked at are age, location, margins or zone of transition, periosteal reaction, and also the matrix. So first thing we're going to do is look at age. So Ewing sarcoma and osteosarcoma are clusters that usually happen in children and young adults. And myeloma and metastasis typically are clusters that happen after the age of 40. The next thing we're looking for is the location. Where is it happening in the bone? And where is it happening in the skeleton? All right, so in terms of the bone, they're looking for things like, is it happening in the epiphysis or the metaphysis? All right, and skeleton, we're just talking about overall, where is the cluster occurring in the skeleton? All right, the next thing they're going to be looking at is the margins or the zone of transition. All right, because that's going to suggest, is it benign or is it malignant? So for benign tumors, there's typically a sharp, narrow transition to normal bone. And in your malignant tumors, there's usually a wide or fuzzy transition, and that's going to suggest that the tumor is acting very aggressive. All right, the next thing that we're going to look at is the periosteal reaction. All right, so we're looking for things like a thin, solid transition. All right, that's showing you that it's a calm transition. Or we're looking for an onion skin layering or a Codman triangle. That's going to signal that it's a fast growing lesion. All right, the last thing that we're looking at is the matrix. All right, this is the internal pattern, and the pattern that presents is going to hint to what type of tissue the tumor came from. All right, now we're going to look at a few case files, and when we're looking at these case files, we are trying to show you the difference between that polite guess, that benign tumor, or the break-in, which we're talking about, the malignant tumor. So the first case files here is on osteochondroma, and that is one of the most common benign bone tumors. It does typically happen when we have a lateral part of the growth plate growing abnormally. As it's growing abnormally, it's producing a cartilage cap bony projection that's continuous with the bone underneath, typically in the area of the metaphysis of the long bone. Patient age for this particular condition usually ranges anywhere from the age of 10 up to the age of 30. All right, the thing we are looking for here is continuity. All right, we're looking for things like the lesion's cortex and marrow flowing directly into the host bone cortex and marrow. The next case file we're going to look at is osteosarcoma. So we're talking about a malignant bone tumor. It's the most common primary malignancy that they can find in bone. It does have a bimodal age distribution, so there's two age groups. It usually peaks in adolescence around age 19, and also there's a peak in older adults. The location where it typically shows up is either in the knee or the shoulder, and it is a very aggressive lesion. On films, it has a poorly defined margin. There are soft tissue mass involved, and also there are those classic periosteal reactions that we talked about earlier. So we're talking about the onion skin layering or the Codman triangle. Also, if you do recognize this pattern, it's an urgent clue that this patient needs follow-up. So this is not a routine scheduling where we can wait weeks and weeks and months to get this patient scheduled. This is a follow-up that needs to happen as soon as possible. Next to osteosarcoma, we have the case file for multiple myeloma. All right, multiple myeloma is a malignant growth of plasma cells that are located in the bone marrow. They don't technically consider this to be a bone tumor because it arises in the marrow, but we still do count it in the group. The most single common primary bone malignancy is multiple myeloma, and the patient age range that it strikes is typically patients over 40. Most often those patients are around age 60. This is a whole skeleton disease, so it doesn't show up just in one bone. All right, there's typically going to be lots of small lesions scattered around and across the vertebrae, the ribs, the pelvis, in the skull. So we're not going to just see one dominant mass, it'll be scattered throughout the entire skeleton. If we're looking at this on a lateral skull film, it kind of produces what we call a raindrop skull appearance. So why do you care about bone tumors as a technologist? Well, the first reason is because you are the first person that will actually see the patient, and you're the person that is responsible for getting those diagnostic images that will ultimately lead to that patient's diagnosis. So the first thing you want to think about when you're imaging, even though you're not making the diagnosis, is the patient's age can narrow down the type of bone lesion that you're looking at. The second thing is we always want to make sure that we are going to get a complete series of that patient. When I talk about a complete series, sometimes when we're looking at lesions, even if it's incidental, it usually leads to the patient getting something like a skeletal or a bone survey, something that most technologists don't like to do because it's a lot of images on the same patient. You're basically imaging every part of the patient's body. So with those images, you're going to make sure that you're getting all of the bone itself in the lesion. So we're not trying to crop really tightly. We want to get, the entire bone from top to bottom. All right, the next thing is being able to recognize something that is aggressive or looks aggressive, having those fuzzy margins versus something that looks a little bit more slow in growth, all right, the very sharp margins. All right, and the examples that were given as we were going through that particular slide was you're looking for, if it's aggressive, that wide zone transition. We're looking for fuzzy margins. We're looking for that Codman triangle. All of those things will tell you or identify that that patient needs to be seen right away. There's the faster you can get them to their follow-up services, the better, because we're talking about a fast growing cancer. If we're talking about a cancer that's metastasizing, is leaving the point of origin and traveling to different parts of the body. All right, last thing you want to look at or remember as you're x-raying these patients, everything that looks abnormal isn't necessarily alarming. Things like bone islands, small osteochondromas, fibromas that are healing, all of those may look strange, but they're not necessarily alarming in terms of the fact that they're not that fast, aggressive tumor that we're looking for. All right, as with all of our chapters that we've gone through so far, here's our quick little cheat sheet. All right, and this is to basically put some of the tumors into the bucket of being benign or malignant. So the first category that we looked at is your osteochondroma. It was considered to be benign. For appearance, it has a cartilage capped outgrowth, continuous with the cortex. All right, a presentation of nighttime bone pain that's relieved with aspirin. We're looking at an osteoid osteoma, which is benign. If we have an onion skin periosteal reaction and there's some soft tissue mass, and we're talking about a teenager, we're looking at an osteosarcoma, and it is malignant. If we're looking at a patient over 40 that has multiple lesions that appear punched out, we're looking at a multiple myeloma, and it is malignant. If we're looking at a moth-eating dysphacial lesion and the child is presenting and they have a fever, we're looking at a Ewing sarcoma, and it is malignant. And then last but not least, if we're looking at a ground glass lesion with deformity, we're looking at a fibrous dysplasia, and it is benign. Now we're moving on to chapter 14, and in that chapter, it discussed endocrine diseases, metabolic diseases, and also nutritional diseases. So every week so far, we've had that analogy going on. So with this chapter, there was a construction site analogy that was picked. So with this one, in terms of construction or building something, someone's typically going to be in charge, and you have to have the correct materials to build. And once those materials are ordered, they actually have to show up to make things happen. All right, so that is the analogy that is used for this particular chapter. All right, now we're going to look at the three categories in which our skeleton can fail. So in terms of skeleton, again, the analogy is the construction crew, and the skeleton is the actual crew that we're talking about. So the categories are bad orders, renovation outpaces construction, and materials never show up. In terms of those categories as well, category 1, bad orders, that is going to be your endocrine system. When we're talking about the second category, renovation outpaces construction, we're talking about metabolic categories. And then your last one, materials never show up, we're talking about that nutritional category. All right, so looking at the first category, it says that we have bad orders from the head office. We have all sorts of glands in our body. Some specific ones are our hormone gland, the pituitary gland, and also the parathyroid. All right, they all give us hormones in order to help build and also sustain our skeleton or sustain our bones. All right, so when those glands are sending out too much or too little signal, too much or too little hormones, our skeleton will either overbuild or underbuild in response to the hormones received. All right, and we said that was the endocrine category because all of those glands fall into the endocrine system. All right, the next one is renovation outpaces construction. So our bones, over time, they break down, they rebuild themselves. All right, when the metabolic system is malfunctioning, for instance, the breaking down is outpacing the rebuilding, that's when we see conditions such as osteoporosis. All right, last category is the materials never showed up. All right, and this is the nutritional category. Do we have enough nutrition for the bones to be healthy? All right, so we have vitamins that are necessary in order for our bones to be healthy. Typically, we're talking about vitamin C, calcium, and also vitamin D. All right, if we're not getting the proper amount of those via our food or supplements, then our bones can't properly build or sustain themselves. All right, and as a result, there will be a breakdown. So again, that is the nutritional category. So now we're looking at our sorting buckets again. So we're sorting if it's fallen into an endocrine system failure, a metabolic failure, or a nutritional failure. So we're looking at endocrine disorders, metabolic disorders, and also nutritional disorders. So the first bucket is, the skeleton is giving bad orders, or the gland that is involved in producing those hormones for the body or skeleton to function properly are either not signaling enough or not producing enough of the hormones or producing too much of the hormones. Conditions that fall into this category are acromegaly, hyperparathyroidism, Cushing syndrome, and also hypothyroidism. The next category is the metabolic disorders. All right, so our bone is not restoring itself fast enough per se. Conditions that fall into this category are osteoporosis. So the bone is breaking down, it's not as strong as it should be. And the last one is nutritional disorders. So it says missing materials, you're not getting the proper nutrition or vitamins that you need for your bones to stay healthy. And conditions that fall into this category are rickets and also scurvy. Now we're going to move into our case files, and in the case files we are going to present endocrine disorders. So the category where we talked about bad orders were given. We're going to look at the metabolic disorders where there's an imbalance in the remodeling, building up versus breaking down. And last but not least, we're going to look at those nutritional disorders where we don't have the proper material. So in the case of nutrition, we're talking about the vitamins that we need for our bones to sustain themselves. So the first condition we're going to look at is acromegaly. And this happens when we have an overactive pituitary adenoma. So we're talking about a tumor, a benign tumor in the pituitary gland that is causing the gland to overproduce growth hormones. Now, in the case of acromegaly, the growth plates of this patient have already closed. So as a result, the growth plates have already closed, so of course the bones can't get any longer. So they're going to get thicker and they're also going to get wider instead. The opposite of this would be if we're talking about this happening, this overproduction of growth hormones happening in a child where the growth plates have not closed yet. All right, if the pituitary gland is overproducing in the case of a child, it would result in the condition of giantism for the child. Now, one of the signs for acromegaly is that the patient will often have, you can see it oftentimes in their hands and the feet. You can see soft tissue and also bone overgrowth. Our next case file is for osteoporosis. So we're looking at a metabolic disorder. Osteoporosis is when the bone density of the patient is deficient. So their bone density there's loss in that bone density. It is common. It's a common form of osteopenia, and it affects more women than men, especially older women, typically over the age of 40. As a result of a patient having something such as osteoporosis, they may develop fractures. So on plain films, this is typically not visible until that patient has lost about 30 to 50% of their bone density already. So it won't be visible until this condition has progressed. A common fracture that you might see in a type of, in this patient that has osteoporosis would be a fracture in the area where the thoracic spine and the lumbar spine meet. That's usually where the first signs of osteoporosis appear. And usually that fracture can occur without any type of trauma. The last case file we're going to look at is the case file on rickets. And rickets is where we have that lack of nutrition. All right, rickets is a failure to mineralize growing bones. Typically, that deficiency is in either phosphates, calcium, or vitamin D. And it's a pediatric version of osteomalcia. Now, rickets is, in terms of films, it shows up where growth is happening fast. So we're talking about in the growth plates, and it shows up as a widened, cupped, or frayed metastasis. And the signature finding for that, when we're talking about kids that are ambulatory or able to walk, their bones are so soft that under pressure, they start to bow. So we're talking about that condition of bow legs. Now we're getting towards the end of the chapter, and this particular slide is covering what we consider the fine details, so the fine details in our image, and also handling some of these patients gently. So when we talk about fine details, on a film, some of the early signs of hyperparathyroidism is seen in the middle fingers of the patient, specifically on the radial side. And if we're not careful with our techniques, or we're not shooting the patient with a good technique, some of those details might be missed. In our patients that have osteoporosis, a lot of times we're talking about our elderly population. For many of these patients, their bones are very weak and very thin, and that does put them at a higher risk for fracture. So we do want to ensure that we are handling them gently, the same as we would handle patients that have hemophilia and also osteogenesis imperfecta. In terms of osteoporosis, we typically are not going to see that condition manifests on our film images until that condition has progressed and is in its more advanced stages. So by the time we see some of these um, findings on an image, like in hyperparathyroidism and also osteoporosis, the condition has, advanced. The last one is in our pediatric patients, those that have rickets, that pediatric bowing of the legs. We do want to pay attention to those patients because some of our normal positioning landmarks will not be in the same place as for our normal patients. Just like when you went through the chapter, I think it was chapter 8 on dysplasias, where you have your patients that have, the shorter limbs and also changes in their pelvis and spine. Some of the landmarks might be different. So of course that would require us to change some of our typical positioning that we would do for our average normal patient. To end the chapter, we're going to look at our quick reference chart again, run through a few of the conditions along with their presentation. So the first one is a failure of the endocrine system. So we're looking at acromegaly. In this particular patient, they will present and have enlarged hands, feet, and also their jaw. And this is a gradual onset, but this is the presentation in an adult patient. The next one is another failure of the endocrine system. It's called hyperparathyroidism, and it's usually seen as a subperiosteal resorption, typically in the radial middle phalanges. So we're talking about the middle fingers. All right, moving on, we have osteopenia. So we're talking about a lack of bone density. In addition to that lack of bone density, there is a compression fracture in the spine, typically in an elderly patient. This is a metabolic failure, and this is the condition of osteoporosis. All right, the next one is a toddler presenting with legs that are bowing, so bow legs. Also, they will have a cupped and frayed metaphysis. This is a nutritional deficiency, and it is considered to be that condition of rickets. The next one, we will see a patient. They have a round face. They might be obese. Typically, they're going to have short fourth and fifth fingers or metacarpals. And that condition is a failure of the endocrine system, and it is called pseudo-hypoparathyroidism. And last but not least, we have what we call a rugged Jersey spine with a salt and pepper skull. That is a failure of the endocrine system as well, and that is called hyperparathyroidism. Again, just like the radial middle phalanges that we talked about earlier, both of those are failures of the endocrine system as well. Our last chapter for the week focuses on what we consider to be miscellaneous bone diseases. So they don't fit in a nice little group like the others. They still do have a couple patterns that show up, and we're going to try to organize by those patterns, but they don't fit into the nice little group like the other bone diseases. With our miscellaneous conditions, they don't fit into those nice buckets that the endocrine, nutritional, and metabolic conditions fit into. But even though they don't fit into a nice bucket, there were still some patterns that we'll see in some of these conditions. All right, the patterns are listed here. There's two of them. The first one is that there is something that is building up. Typically an abnormal substance. It can be a protein, it can be a fatty cell, or it can be a heavy metal. The buildup happens or collects around the bone and also the bone marrow. The second bucket or category that these miscellaneous conditions will feature is the bone structure itself is changing. So how the bone is remodeling itself, how the nerves are growing into the bones, and also how the spine lines up. And this is independent of the buildup. So it's either going to be the shape changing or something is building up. So again, it doesn't fit into a nice little box like our endocrine, metabolic, and nutritional conditions, but there are still some patterns that we can use to identify what's going on with the patient. On this slide, we're going to look a little bit deeper into those two patterns, the pattern where something is building up, something abnormal is building up, and also the second pattern where the shape itself is changing. So the first pattern that we're going to look up here, we have some sort of abnormal substance that's collecting, typically around the bone, in the bone, or in the bone marrow. And there's a few examples here. The first one is amyloid. With amyloid, we have an abnormal protein that's building up in the patient's tissues. The condition itself, one of the conditions is called amyloidosis. The next one is lipid-laden cells. So basically, we're talking about a cell that has a lot of fat in it, like a lipoma. Typically, these are going to be benign fatty tumors, but they are located inside of the bone. And last but not least, we have some type of heavy metal that is building up. One type of metal that might build up would be lead. This heavy metal itself is depositing inside of growing bone, and it can actually show up on x-rays. All right, the next pattern is the shape is changing. So we don't have any buildup here, but we do have the structure or the shape not presenting the way it should be. So it's the structure itself is failing or something's going wrong with the shape. So the first one is Paget's disease. With Paget's, the bone itself is remodeling abnormally. So when or where bones break, or break down and rebuild themselves. With Paget's disease, it's rebuilding too fast. And as a result of rebuilding too fast, it doesn't do a really good job building. So it's kind of a messy process. The next one is scoliosis. That's when the spine is curved out of alignment. And then the next one, or the other one in that category, is neurofibromatosis. With that one, we have nerve tissue that's not growing properly. And it will, as a result, because it's not growing properly, it will reshape the bones that are nearby, or it will cause things to bow. So again, these are conditions that don't fall into the nutritional category, the metabolic category, or either the endocrine category. Now we're moving on to our case files, and the first case file is about Paget's disease. In Paget's disease, we're talking about those structural bone changes. Paget's disease typically runs in families, and the disease actually makes certain bone cells, specifically osteoclasts, go into overdrive. So they're working overtime. So in terms of the remodeling of the bone, it gets a little bit chaotic. This condition is common in people that are typically over the age of 40, about 3%, and then some patients over the age of 80, about 10%. With this condition, it does have 3 phases, and those phases are the bone breaks down, then it gets mixed, and then it starts to rebuild. Most bone diseases will make the bone thinner, but in the case of Paget's disease, it does just the opposite. So the bones get bigger, and they also get a lot denser. 3 things that they look for to identify Paget's disease is enlarged bones. They also look for thick bones or thicker outer layers of the bones, and also the inner mesh of the bone or the inner workings of the bone looks a little bit coarse, and it can also be described as looking a little bit heavy. So all 3 of those things together is what they use to identify Paget's disease. We looked at Paget's where we have something going wrong with the structure. So now we're going to look at the second case file of miscellaneous disorders, and that is going to be Gaucher disease. With Gaucher, we're talking about something building up, and Gaucher is typically an inherited fat storage disorder. So the body itself is missing an enzyme. So with that enzyme being missing, we have what we call fatty deposits start to line up or pile up or build up inside of the marrow cells. It's typically going to be worse in kids. This was a common disorder that was seen in some of patients that had Jewish descent. So again, with this Gaucher disease, we have a buildup that crowds out the normal bone marrow. And that crowding will eventually squeeze on blood vessels. And if the blood vessels are squeezed on, it's going to cut off the blood supply to the bone. So similar to that avascular necrosis that we talked about last week, it usually is found somewhere around the femoral head. All right, some things to keep in mind as we were talking about those miscellaneous bone disorders or diseases. We're going to go through Paget's disease, cafe au lait spot borders, and also that Gaucher disease and amyloidosis. With Paget's disease, sometimes it can look a little bit like cancer on an image, so it is definitely up to the radiologist to figure out what it is. With that patient, they might have bigger bones. Those bones also might have a coarse texture, and all of that will help the radiologist tell them apart. The next one is cafe au lait spot borders. And we're talking about smooth edges versus jagged edges. If they are considered to have smooth edges, we're looking at a neurofibromatosis. And if they have jagged edges, we're looking at fibrous dysplasia. Last but not least, with Gaucher disease and amyloidosis, they don't want to just look at one thing. They're usually going to check the entire body, not just that one spot. If they did not do that, they might miss a pattern and misdiagnose the patient. So again, with Gaucher disease and amyloidosis, they're going to check the whole body or entire body, not just for one spot, to figure out what is going on with the patient. Moving on to our quick reference cheat sheet for chapter 15, the miscellaneous conditions. We're going to start with Paget's disease. There's a couple on here for Paget's disease. The first one is the bigger bone or larger bone that has a thick cortex and a coarse texture, specifically in older patients or older adult patient. That is a sign of Paget's disease. The other one here is we have a cotton wool skull. That is another sign that points to Paget's disease. The next one is the flask shape, and the patient might present or have an enlarged liver or spleen. That is a condition or sign of Gaucher disease. The next one where the patient presents with or has what we call cafe au lait spots. When we're talking about the borders, they're smooth. They also might have skin nodules, and that is your neurofibromatosis. The next one is in a kid. If we're looking at the growth plate and we see dense lines, that is a sign of lead poisoning. And last but not least, we have spine curves. Specifically, if the spine is curving sideways, there are other curvatures that the spine can have, but here we're talking about a sideways curve. Typically, the radiologist will have to measure the angle of the curve. We're talking about the Cobb angle, and this signals that the patient might have scoliosis. So this concludes this week's requirements. We had this week chapter 13 talking about bone tumors, whether they were benign or malignant. With your benign tumors, they behaved as those polite guests, staying within the borders. And with your malignant tumors, they did not play by the rules. The other chapter was chapter 14, endocrine, metabolic, and nutritional disorders. We categorized them as bad orders, meaning the glands were not producing the hormones as they should. They were either overproducing or underproducing. With the metabolic disorders, we had imbalance remodeling. So basically, as the bones were growing and rebuilding themselves, they were not able to do it sufficiently. So that one of the conditions that we looked at there was osteoporosis. And last but not least, the missing materials. We had a deficiency in nutrition, typically in the vitamins. And as a result, conditions such as rickets would develop, presenting in children as bow legs. The last chapter was the miscellaneous bone disease chapter. In that chapter, we had two categories that we were looking at as far as patterns. Something was building up abnormally, or we had some type of structural changes within the patient. So again, these were the chapters. I hope that you learned something as far as some of these patterns go. Also, in terms of your job as a technologist, I hope you learn that some of these conditions will require you to vary your technique and also require you to vary how you handle and care for the patient based on their condition.